Well, thank you very much. I've got to confess, I'm ever so slightly nervous right now. I've been walking around the conference this morning and I've been looking at some of the fantastic things out there. And my sense of anxiety has been growing as the morning's gone on. Not because you're a particularly rough crowd on the whole, but because I've been asked to talk about the value proposition. And the value proposition itself is really quite a simple concept, quite a simple idea. And I'm looking around this conference, and I'm looking around some of these stands, and I'm thinking to myself, you guys probably know more about the value proposition than I do. So what am I doing standing on the stage talking about it? Because the value proposition is something that whether we're in business or not, whether we've got a medical device product or not, whether we're in the game of selling stuff or not, is something we're all very familiar with. I'm no doubt going to do a bit of value propositioning myself on the way home tonight, thinking it's been a long day and a long week. I might well stop at Sainsbury's on the way home and get a bottle of wine for my tea. And as I walk into Sainsbury's and go down the shelves and look at all the bottles of wine, I will be doing a calculation in my head around the value proposition. I'll be saying to myself, what sort of wine do I want tonight? Do I want a New World wine? Do I want a French wine? How much am I prepared to pay for that? Do I want a fancy label to impress my guests? Do I want a fancy grape or whatever? And as I'm doing that calculation, as I'm doing that reasoning, I'm going to be thinking, how much am I prepared to pay for this bottle of wine? Of course, Sainsbury's have already done that calculation for themselves. They've been thinking, what sort of a sucker am I going to be walking into Sainsbury's today buying my bottle of wine? They'll be trying to catch me in with all sorts of clever things. So this idea of the value proposition is something which is very familiar to all of us, to all of you. So what's the point of having somebody like me stand on the stage today and talk about the value proposition to a bunch of people who probably know more about it than I do? Well, my 30-something years experience in the NHS has taught me that on quite a lot of occasions, people with really rather clever medical device ideas and medical device products don't actually understand the value proposition of their device, or if they do understand it, they're not very well equipped at being able to explain it and illustrate it in a language that the people who are going to buy it, or they're hopefully going to buy it, will understand. So we found out in our game that actually describing the value proposition of a medical device, a medical technology, can be quite tricky. So this afternoon then I'm going to just really introduce you to three very simple tools, and they are almost embarrassingly simple, as you will see in a minute. Three very simple tools that we've developed in Nottingham to help people describe the value proposition of their medical device, their medical technology. I perhaps ought to start by explaining the split personality that I've got at the moment. I noticed I was introduced today, thank you very much for this warm introduction, as coming from Nottingham University, which indeed I do. I work as a professor at the university where I help a lot of people translate their ideas for medical device technology into the real world of the NHS. So I do work at the university. But my main job, I guess, is as head of service at the hospital in Nottingham, Nottingham University Hospital, NHS Trust. My badge says that I'm from NICE. And indeed, I do work at NICE for a couple of days a month, helping them on adoption recommendations for new technologies into the NHS. But what I'm going to talk about now is around what CEHTA do. And I should just quickly explain that CEHTA was an organisation that we founded in Nottingham about 3 years ago. CEHTA is the Centre for Healthcare Equipment and Technology Adoption. And CEHTA was specifically designed to help manufacturers, notably small manufacturers, understand the pathway from concept to adoption and diffusion of technology in the NHS, and provide a range of services and products for manufacturers, for particularly small manufacturers, in helping them to do that. And one of the key areas that CEHTA have worked in is this idea of describing the value proposition. And like I say, we've got three key steps, and they are very simple, but very important to understand and get right. And they are what we call the matrix, framing the claim, and then the WWW of medtech adoption, which is the who with what. So I'll talk through those very quick steps now, and then I'll illustrate them with three examples. The matrix then is so simple, embarrassingly so, that we've tried to jazz it up with a flashy name and a flashy slide now to make you think it's more important than it is. It is simple. It is nothing like as complicated as the plots and subplots that poor old Keanu and his mates had to delve through within the film. It is a simple device. Before I describe that simple device, I'm going to introduce you to two concepts which you probably know, and you could probably describe to me, but I'm going to bash on with it anyway. The first of those concepts is patient benefit. Now, intuitively, we all know what patient benefit is. Patient benefit is doing something which improves either the outcomes or the experiences or something to do with helping the patient feel better about themselves. So we know what patient benefit is. You can ask anybody. You can ask a doctor, you can ask a nurse, you can ask a physiotherapist, you can ask anybody in the stands outside here what's patient benefit, and they'll be able to describe that to you. Measuring it, quantifying it, putting a number on it might be more difficult, but people instinctively know what patient benefit is. The second idea is healthcare system benefit. And again, we can probably all describe what the healthcare system is. The healthcare system is not just the single procedure, the single application of your technology where you use it. The healthcare system is the whole pathway that the patient goes through. So a patient turns up in the healthcare system and goes through a whole pathway. If we introduce technology, that's only part of the pathway, but it's the whole system that we need to be interested in. And I guess what I really mean when I say the healthcare system, I mean cash pound notes. I mean, how much does it cost the system to look after that patient? So we've got these two ideas. We've got patient benefit and we've got healthcare system benefit. If we introduce a new technology into the patient pathway, if you have a product that we can sell into the NHS, then it's going to have an effect on healthcare benefit, on patient benefit, and healthcare system. And in fact, if you put it into the system, that doesn't have to be a technology. If it's a drug, if it's a new way of working, if it's a new intervention, it's going to have an impact on patients, patient benefit, and it's going to have an impact on the healthcare system. Now, that impact might be good or bad. So it might be good for our patients, better than we do now. If you put in a new technology, and we've got lots of new technologies out there at the moment, if we introduce them into the healthcare, it'll probably improve patient benefit. So it might improve patient benefit. It might actually just be as good as what we currently do, the current technologies and the current ways of working. Or, strangely, there are some technologies which we might introduce which could be worse for our patients. They could actually have a detrimental effect on patient benefit. So there's three things that they could do then when we introduce that technology. And you can apply the same thing to the costs, the healthcare system. If we introduce a new technology, it might be incredibly expensive. It might push up the cost of providing care for our patients. Not just at the point that we provide that, but across the whole system, the whole care pathway. So it might push up costs, or it might cost about the same as it's currently costing to look after those patients, or it might be cheaper overall. So you can see, this is where the matrix comes in. If we plot patient benefit against healthcare system benefit, we've got one of 9 states that your new technology, your new intervention, your new medical device could have. The green squares are good news squares. So if you've got a new technology that we introduce into the healthcare system and it is better, it improves patient care, it's better for our patients, and it reduces the cost of the whole healthcare system, then you're in the top right-hand box of the matrix. And that's going to be good news. Why would we not, as the NHS, why would we not want that technology adopted into our healthcare system? Conversely, of course, if you're in the bottom left-hand square here, if you've got a new technology that when we introduce it into the healthcare system costs us a lot more money and is perversely worse for patient benefit, then nobody wants that, thank you very much. If you're in the business of making a device like that, stop now and put your time and energy and skills into something else, because we don't want products in the bottom left-hand side of this graph. And then that middle diagonal there is what Jeff Boycott would call the corridor of uncertainty. If you're in that area, you may have a product that the NHS wants, but it's going to be hard work convincing the NHS or any modern healthcare system that it wants it. If you're in the, if you've got a product which is more expensive but better for patients, well, sometimes we, the NHS, the healthcare system, is going to want that. But on other times, if you spend money on your product, the NHS has a finite and indeed reducing pot of money to spend on. If I spend money on your new technology, I've got to take it away from somebody else's healthcare. So that gap in benefits got to be much, much better for your new technology than for the existing one. So that is step one. If you've got a product, if you've got a new idea, if you've got a new way of working in the NHS, where does it sit in the matrix? If it sits in those green squares, fantastic. Let's develop that. Let's look at ways of taking that forward. If it sits in the red squares, I think you should take a long, hard look at that technology and decide whether you really want to invest your time and energy and skills in developing it. And if it's in the middle, well, we've got some work to do. Step one. Step two, then, is a thing that we refer to as framing the claim. I've been there, I'm still there actually. I'm a research scientist by background and developed lots of new ideas. And when you're an inventor of a new idea, you think it is fantastic. You invest a lot of your time, your energy, your skills into that new idea, and it's the best thing since sliced bread to you. And we have a habit when we've got to that point, when we apply that product to healthcare, of over-egging what our product can do. We tend to say all sorts of things that it can do, a whole pile of stuff. But actually, what's the core thing? What's the core claim that you're making for your technology in healthcare? What's the core thing? Don't try and suggest, it can also do a whole pile of other stuff. Think about the core thing, the key thing that the technology does. And I'll come back to that and illustrate it with a couple of examples. So step 2 is identifying the key claim for your product. Yes, I mean, that's just an example there of also makes the T as one of the expressions that we use in some of our feedback to people. But they have products that can do absolutely everything, but you can only, we must concentrate only on those claims that we can back up with evidence. Don't suggest it can do things that we can't. Here's some typical examples of the 1950s of people making claims for products. I'm sorry, you can't see it from back there. In fact, the text is so small and blurred, I can't see it from back here. But this is an advert, as you can see, for a non-medical device. But it's an advert for cigarettes. And I love the fact that it talks about scientific evidence, Mark, not just any old rubbish evidence, scientific evidence, that there is no adverse effects of smoking this particular tobacco. If you can't read it, but if you look really closely, 45% of patients in this cohort, 45%, and you realise that the cohort is actually only 20, so I'm showing you 45% of 20s, reported no adverse effects. So that's scientifically proven evidence. So don't drop into the idea of making claims for medical device products, your new products, that you can't back up with evidence. Okay, and finally, who with what is the third step that we apply. And who with what is all about working out who are the payers, who are the people with the purse strings, who are the people you need to convince. If you've got healthcare benefits, if you've got patient benefits, it's fairly obvious that you can convince healthcare professionals. That's what we do in hospitals. We want things better for our patients. So if you've got evidence that it improves patient outcome, we're easy to convince. If your evidence, though, is that it's across the wider system and it saves money, most doctors and nurses and other healthcare professionals are not that bothered about that, but my general manager and my director of finance would be. So who with what is all about understanding who it is that you need to convince and what evidence do you need to put in front of that person to convince them that your product is worth investing in the NHS. It's all a bit abstract, so I thought I might try and illustrate that with a few examples of devices which we at Cheetah have helped, or Cheetah staff have helped. It's quite difficult for us in Cheetah because obviously by the nature of the work we get, we work as consultants to medical device manufacturers and new technologies, and all that information that we provide to them is of course confidential, so we can't give you, it's difficult to give you live examples. So the 3 examples I've picked are ones where Cheetah staff have been involved in supporting technology which has ultimately gone to NICE, which is what it says on my badge, has gone to NICE for adoption into the, for recommendation for adoption into the NHS. So the first example that, some of you may have heard of this product, is a product called the Inditherm. The Inditherm is a solid state hospital mattress for operating tables. We have a number of procedures in hospitals, particularly long theatre procedures, where keeping the patient warm is a problem, and a cold patient doesn't do as well. So we have to keep our patients warm, and there are conventional ways of doing that now, which are generally about forced air. So they're basically big hairdryers and blankets that we keep our patients warm. Inditherm breaks into that market and says, you don't need to do that. The mattress itself warms up. It's a solid state device that warms up the mattress. When we looked at where does it sit on the matrix, we had to do quite a lot of work on this one. What's the cost and patient benefit? Well, we have clinical evidence that Inditherm, the solid state mattress, keeps patients as warm, not better, as warm as forced air warming. So it sits on the patient benefit in that middle column, but it's cheaper. It's not fantastically cheaper, but it's cheaper than using forced air warming. So in terms of where it sits on the matrix, it sits in the green boxes at the top. In terms of the claim, what could we back up with this claim? We couldn't claim that it made the tea, but we could claim that it kept patients as warm. As I said, not warmer. It's not better for our patients than forced air. It's about the same. But we had 5 published papers in peer-reviewed journals that said it's as good at maintaining the right temperature for our patients as forced air. So that's where it sits there, and we have cost models to demonstrate that we've worked up. Then in terms of the WWW, the who with what, who are we going to convince about this? This is a relatively straightforward new technology. It doesn't disrupt what we do in hospitals particularly. The operations take place in the same way. The patient goes through the same pathway. The only difference is we swap out forced air and we put in Inditherm. So it doesn't disrupt. So all we need to do is convince local clinicians that it's better and local hospital managers that it's cheaper. So that's what we did with the who with what. That was our target for that. So that was my first example. My second example, I like this example. I use this one a lot, mostly because I do a lot of talking about innovation, about new technologies. I do a lot of work with universities and bright people like yourselves who are coming up with new devices. And there's a temptation to think that all the solutions to the new healthcare have to be shiny boxes and go faster stripes and the latest whizzy stuff. This is one of my favorite devices because it brings a lot of healthcare benefits, reduces cost, and it is a dead simple low-tech solution. This device is called Pleurex, and as you can see, it is essentially a vacuum flask which comes with a small negative pressure inside it and then a number of catheters that we insert. What do we use it for? Well, there's a condition with, unfortunately, some patients with terminal cancer, particularly of the stomach and the lower intestines. These patients have terminal cancer, so we are giving them palliative care. But a consequence of their tumours is that they get a buildup of a fluid called ascites, which leaks into their stomach and makes the tummy swell up. This is uncomfortable, it's unsightly, it's smelly, and every few days that patient has to come back into hospital to have that fluid drained away. And that procedure means they have to take a day and come into the hospital, they have to take a hospital bed or an outpatient couch. They have to have a doctor or at least a practice nurse to do the procedure to drain it out, and then they go home again. And remember, these are terminal patients. These are cancer patients who have not got that long, and they don't want to waste what precious time they have got coming into hospital every couple of weeks to have this procedure done. So Pleurex does that for them. You wear it all the time at home, can be done by a district nurse, and it keeps the patient at home where they need to be. So in terms of a patient experience, where does it fit on the matrix? In terms of patient experience, it's way off the scale. It improves patient experience, patient care, patient benefit off the scale. In terms of where does it fit on the matrix from a cost point of view, a day procedure involving at least a nurse, possibly a junior doctor, taking up a bed in our hospital for a day, compared to staying at home with something which was, and I coined this phrase which has gone down in nice literature now as cheap as chips. In terms of cost for the NHS, for the whole system, this is ridiculously cheap compared to its alternative. So it's off the scale there. So it's in the very much top right-hand corner. In terms of framing the claim, again, we had a lot of clinical evidence for this. And the clinical evidence was all around that it was safe and it did the job. So we had 9 published patients on that, and the cost model was easy. You could write it on the back of an envelope, but in fact, we did it very thoroughly. But it was an easy one to make. What was a little bit harder was the who with what. Because at the moment, all the costs for this procedure are in the acute centre. They're all in the hospital. If we introduce Pleurex, all the costs and the difficulty and the care goes out into the community. And it's a different budget. So the acute hospital has one set of budgets, and the community sector has another set of budgets. And we've transferred the costs into the community there. So we couldn't just rely on, we did, but we couldn't just rely on convincing local clinicians. We had to convince the whole economy, local economy, of what the benefit of that was. So we had to get regional managers, the CCGs and Health Watch on board with that. So those were the people we had to aim at with the evidence. So that was my second example, and my third example was one of the most complex. So I've gone from one of the simplest to one of the most complex in terms of getting a recommendation. This device is called Watch BP, and it's actually just another non-invasive blood pressure meter. There are hundreds of them out there. You know the devices, you click them on the arm, you press a button, it inflates the cuff, deflates it automatically, listens to your pulse as it deflates, and works out what your blood pressure is. There's loads of these devices out there. What's special about Watch BP? Well, what Watch BP did was introduced an algorithm into this which looked at the pulse. Didn't just look at the crossing points. I will spare you the science behind how they measure blood pressure, but they looked at the whole pulse during this period. And usually the pulse is perfectly normal and everything's fine and dandy, and it just gives you your blood pressure measurement. But in a few patients, the pulse will be slightly erratic. And a slightly erratic pulse might be an indicator of AF, of arterial fibrillation. Arterial fibrillation is a key risk factor in having a stroke. So if you turn up at your GP and have your blood pressure taken with this device, if you're perfectly fit and healthy, you do that all the time. We do a lot of BP measurements, of course. Chances are it'll just give you your BP and that'll be that. No change to your healthcare. But you might just be unlucky and have AF and you don't know it because it's undiagnosed, and this device can spot that. So maybe 1 in 100 patients, it raises a little red flag and says, I think this patient might have AF. If the GP then sees that, the GP has to say, oh, I better refer you to the acute centre to do a 12 or a 7-lead ECG to double check whether you really do have AF. So maybe one of those patients, one of those 100 patients then gets sent to the acute centre, has the ECG, and may or may not be diagnosed with AF. If they are diagnosed with AF, they then get sent to the stroke team who will think about, or the anticoag team who will think about prophylactic treatments going forward for this asymptomatic patient to try and prevent them getting a potential stroke in the future. Where does Watch BP sit on the matrix? Well, in terms of patient benefit, it's slight in terms of the whole population. It's slight in terms of the whole population because maybe only 1 in 100 patients get detected on this, and those that get detected, maybe only 1 in 10 of them actually did have AF, and only a few of those actually get prophylactic treatment which prevented a stroke. So it's better for the one person that it picks up, but for the whole population, it's a small increase. In terms of costs, well, on the face of it, this looks like a really hard cost case to make. The Watch BP device itself is not the cheapest NIBP that you can buy. So you introduce costs there because the device itself is more expensive. About 1 in 100 patients get identified as potentially having AF. They get sent off to the acute centre. That's an expensive procedure that they have to have there to get the ECG. Of the few patients that get that ECG and a confirmation diagnosis of AF, they then go on to long-term chronic care to prevent them getting a potential stroke down the line. And that's more cost. So at every stage, we are introducing cost. It looks like there's no way we can make an argument. Except that if it avoids 1 stroke, it pays back. Not only is a stroke a disaster for the person who has it, and a disaster for the family of the person that has it on a personal level, it is a fantastic burden in terms of costs on the NHS to look after that patient for the rest of their lives. So avoiding 1 stroke can wipe out all those extra costs that Watch BP introduced. It was a phenomenally difficult cost case to make, but a cost case could be made. So that's where it fits on the curve. Again, in terms of framing the claim, we had good scientific data. We had a lot of things that said not only is this as good as any other NIPB machine, it can detect in some patients AF. In terms of the who with what, because of that very complicated pathway that only pulls back the savings in so few cases, we couldn't convince a local GP to pay more because the GP wouldn't see any cash pound note benefits. We couldn't even convince the local health community in, say, Nottinghamshire or Leicestershire or Coventry to do it because they wouldn't see the benefits. It had to be done at national level. So the only way to get this convinced was going up and getting nice recommendations to adopt this. So the value proposition is a very simple concept that we're all very familiar with and can do in our everyday life, but describing the value proposition of your medical device can be quite a challenge, and a lot of us are not very good at doing that. We at Cheetah have introduced these 3 really simple steps, really simple tools for identifying and trying to describe your value proposition. The first is the matrix, and that's the most important, really. The first thing you should do, even at the concept stage, even when you're still designing very early on in your product development, start to think about where will my product sit on the matrix. So the matrix is the most important. Claiming the frame sounds like common sense, but just don't get carried away and make claims for your device that you can't back up with hard evidence. And the final one is about understanding the complex nature of the NHS sometimes and understanding who it is you need to convince with what type of evidence. And that's me. Thank you.